All right, let's get right into it. If you're a med student gearing up for the wards or cramming for your boards, you are in exactly the right spot. Today, we're setting the stage for an intense dive into the microscopic mechanisms and the very macroscopic crises of cholera. We're going to take a single brilliantly structured page of medical study notes and unpack it so you understand not just the what, but the how and the why behind this devastating disease.
Take a look at this. It's basically a clinical blueprint for cholera, and it's going to serve as our guide today. I mean, just look at this page. It's a masterpiece of clinical organization. Breaking down a dense topic like cholera into a high-yield, memorable journey is exactly what we need for test day. We've got the agent, the pathogenesis mapped out like a flowchart, the clinical features divided by stages, and the targeted treatments. By the end of this explainer, you're going to have this entire blueprint mentally mapped out for perfect recall.
So here's our clinical roadmap to absolutely master this material. 1. Meet the pathogen. 2. The cellular hijack. 3. Evacuation and collapse. 4. Investigating the culprit. And finally, 5. Resuscitation and specific treatment.
All right, Section 1, Meet the Pathogen.
You've got to lock in these medical buzzwords for your exams. The infectious agent, Vibrio cholera. Make sure you remember it's a gram-negative enteric rod. Where is it coming from? The source is an infected person, and the mode of transmission is the classic fecal-oral route. But here's what makes this bug so clinically aggressive: its incubation period. From the moment of ingestion, it takes just 1 to 5 days for the disease to fully manifest. That is a seriously tight window.
Moving on to Section 2, the cellular hijack.
So, the pathogen enters the gastrointestinal tract, right? But it doesn't just pass through. It sets up shop. It colonizes the environment, multiplies its numbers, and then initiates its primary weapon. It drops a very specific exotoxin directly from its cytoplasm. Since this toxin acts on the gut, we call it an enterotoxin, specifically the cholera toxin.
Now check out this classic AB toxin structure, cleanly separating the two functional parts of this microscopic weapon. On the left, we've got subunit B. Think B for binding. This subunit's job is to literally anchor onto your intestinal mucosal cells. On the right is subunit A. Think A for active. Once subunit B has secured the toxin to the cell surface, subunit A physically shifts right into the cytoplasm of those mucosal cells.
And here's where the deadly cascade really kicks off. Subunit A is inside the cell. What does it do? It activates an enzyme called adenylate cyclase. This is the domino that ruins everything else. Activating adenylate cyclase causes a massive sky-high spike in CAMP, which turns the cell cycle on into overdrive. That crazy elevation in CAMP, that is the exact direct trigger for the hypersecretion of water and electrolytes out of the cell.
Which brings us to the clinical nightmare. Because of that cellular hijack, there is a massive fluid shift straight into the lumen of the gut. Water and electrolytes just pour out of the mucosal cells, and the physical result for the patient is sudden, profuse, watery diarrhea. The microscopic mechanism directly dictates the clinical presentation.
Which leads us to Section 3, Evacuation and Collapse.
Keep your eyes on this ticking clock. Less than 24 hours. This initial stage of evacuation hits incredibly fast. You have a terrifyingly narrow, high-stress window to act before the fluid loss becomes critical and your patient crashes.
During this evacuation phase, the sheer volume of water loss is insane. We're talking sudden onset watery diarrhea happening 10 to 20 times a day. The hallmark appearance you absolutely must memorize for boards is rice water stools. Alongside this, they're vomiting watery fluid 5 to 10 times a day and having abdominal cramps. But crucially, and underline this in your mind, there is typically no fever or malaise. It is a pure, unadulterated fluid purge driven by that enterotoxin.
So you absolutely have to distinguish between this initial water loss phase, the stage of evacuation, and the resulting consequence, which is the stage of collapse. If that massive water loss goes unchecked, the patient rapidly plummets into life-threatening hypovolemic shock.
Once they hit that stage of collapse, the clinical picture is entirely driven by hypovolemia. Their vitals tank. You'll see a spike in pulse as the heart desperately tries to compensate, paired with a dangerous drop in blood pressure. On physical exam, it's classic severe dehydration, sunken eyes, bone-dry mucous membranes, and terrible skin turgor. And because the kidneys are starving for blood, urine output plummets, triggering acute renal failure. If you don't intervene right now, the ultimate risk is multi-organ failure and death. Period.
So how do we confirm this invisible enemy? Section 4. investigating the culprit.
Here's a really interesting clinical pearl. Despite having a crashing, critically ill patient, a basic CBC will often show a perfectly normal white blood cell count. Why? Because the bug isn't in the bloodstream causing a massive systemic infection. The chaos is entirely localized to the gut lumen and driven by that local toxin.
Which brings us to your gold standard exam answer. The investigation of choice is gram staining of the stool. Because we know from the very beginning that Vibrio cholerae is a gram-negative enteric rod, this simple, direct test will light up those gram-negative Vibrios, confirming exactly what's trying to kill your patient.
Finally, Section 5. Resuscitation and specific treatment. Okay, let's break down our two-pronged counterattack. On the left is our resuscitation. This is our mainstay, supportive therapy, and it is your immediate, drop-everything priority to prevent death from shock. On the right, we've got the specific pharmacological fix, antibiotics to wipe out the bug itself.
For resuscitation, you are racing the clock to restore volume, IV fluids instantly, while continuously managing the ABCs, airway, breathing, and circulation. Because their blood pressure is probably through the floor, you might need aggressive inotropes like norepinephrine just to maintain organ perfusion. For the fluids themselves, you're aggressively pushing crystalloids like normal saline and colloids like Hemixel, doing everything you can to yank that patient back from the brink of shock.
Now, only once the patient is hemodynamically stable and volume is replaced do we go after the Vibrio with antibiotics. Our blueprint gives two solid options. The IV route utilizes ceftriaxone at a dose of 2 grams daily for 14 days. Or, for the oral route, you can use ciprofloxacin tablets at 500 milligrams BD, so twice a day for 10 to 14 days.
As we wrap up this explainer, I just want you to step back and reflect on the staggering fragility of human homeostasis. I mean, how does a microscopic elevation in one single cellular molecule, CAMP, lead to total, catastrophic multi-organ failure in under 24 hours? It's wild. It all starts with one little gram-negative rod and its elegant, deadly enterotoxin literally flushing a human's life-giving water away. Mastering that microscopic why is your absolute key to nailing the clinical what on the wards. Keep crushing your studies, stay focused, and I'll catch you in the next one.